Today I'll be presenting on Dupuytren's disease. So by way of background, Dupuytren's disease is named for the French military surgeon Guillaume Dupuytren, who described the natural history, pathology and surgical technique in managing the condition. It's a fibroproliferative disorder of the palmar fascia of the hand, in which excessive deposition of collagen initially results in formation of isolated nodules palpable beneath the skin. Later on, it causes the formation of thick cords along the paths of normal fascial ligaments and bands in the palm and digits. Contraction of the cords over time can cause fixed flexion contracture at the metacarpal phalangeal joints, or the MCP joints, and the proximal interphalangeal joints, or the PIP joints, that limits the function of the affected digits. The prevalence in Western countries is that of between 0.6 and 31.6%. There is substantial regional variation, the highest in Scandinavia and Northern Europe, where patients can be seen. It's commonly found in males aged above 40 and typically in the ulnar digits. Risk factors include older age, male gender, Caucasian race, history of smoking, alcohol abuse, systemic conditions such as diabetes, liver disease and epilepsy, work exposure, manual and vibrational work exposure. Interestingly, obesity actually reduces the risk. Dupuytren Diathesis refers to a higher-risk subset of patients with aggressive early onset disease. These patients often have a family history and bilateral hand involvement and other sites of disease. These include the knuckles, where they're known as Garrett's nodes, plantar fibromatosis, or Lederhose's disease, penile fascia, or Peyronie's disease. These patients are notable because they're at high risk of disease recurrence. So reviewing the relevant anatomy, the palmar aponeurosis is the thick triangular fascial layer that covers the lumbrical and flexor tunnels between the thenar and hypothenar eminences. Distally to the palmaris longus, these are made up of longitudinal bands called pretendinous bands. These continue into the digits as spiral bands deep to the neurovascular bundle, and then they become superficial. The natatory ligament is a horizontal ligament that passes between the web spaces. The lateral digital sheet is superficial fascia on either side of the finger, with contributions from Cleland and Grayson ligaments. Normal fascial structures are bands, but when they become diseased, they are referred to as cords. There are some main cords in Dupuytren's with associated deformities, which are pretendinous cord, which causes MCP contracture, central cord from diseased central fibrofatty tissue, which causes PIP contracture, spiral cord, which displaces the neurovascular bundle towards the midline, lateral cord from a diseased lateral digital sheet, which contributes to distal interphalangeal or proximal interphalangeal contractures. Natatory cords from diseased natatory ligaments result in web space contracture. The pathophysiology is characterized by increased collagen and extracellular matrix production. Predominance of type 3 collagen leads to increased type 3 to type 1 ratio. In terms of the histology, fibroblast proliferation and differentiation to myofibroblasts is seen. The differentiated myofibroblast is considered the primary pathologic cell of Dupuytren's disease. Its fibroblast lineage allows it to produce collagen. Profibrotic cytokine transforming growth factor beta, or TGF-beta, is integral in disease development. It allows for differentiation of fibroblasts into myofibroblasts, stimulates collagen production by myofibroblasts, and stimulates contraction. The renin-angiotensin-aldosterone system likely has a role. There is extensive expression of angiotensin II receptor in tissue samples. These could be potential targets for future medical therapy. There is a strong genetic predisposition. A mutation in the gene encoding for SFRP4 is the most highly associated. This leads to increased production of alpha smooth muscle actin, which contributes to skin dimpling and contracture formation. In this figure, we can see the typical histological appearance of mature fibroblasts in collagenous tissue. Collagen fibers are stained pink. The fibroblast nuclei, which is labelled F here, are condensed and elongated in the direction of collagen fibers. The cytoplasm is relatively scanty and barely visible. The cell is long and thin, with fine cytoplasmic processes extending into the matrix. In figure B, we can see active fibroblasts, called myofibroblasts, in repair of damaged tissue with early fibrosis and scarring. The nuclei are large with prominent nucleoli, and the cytoplasm is extensive and basophilic. A few eosinophils, labelled EO, and lymphocytes, labelled L, are present. In terms of the clinical presentation, patients will present with difficulty with their fingers getting in the way of washing their face or combing their hair, putting a hand in their pocket or glove, racket sports and golf. Initially, it presents with a painless skin thickening, pitting or palmar nodules. The differential diagnosis at this point also includes stenosing tenosynovitis, skin callus, or a soft tissue tumour. The ring finger is most commonly affected, followed by the little finger, the middle finger, the index finger, and the thumb. Generally, it progresses from the palm towards the metacarpophalangeal and proximal interphalangeal joints, although in some cases it may be isolated to the digits. Disease progression from nodules with cords and progressive contractures at the MCP, PIP, and DIP joints is seen, with loss of function. 50% of patients with palmar nodules progress to develop cords. A positive tabletop test is one diagnostic tool that is often used to indicate patients for an intervention to resolve the contracture. You ask the patient to lay their palm down on the table, and it's positive if you can slide a pen underneath it. This indicates a metacarpophalangeal joint contracture of between 30 and 40 degrees. Classification can be histological or clinical. The histological classification is the Luck classification. It includes 3 stages: proliferative, involutional, and residual. This corresponds to the maturation of the fibroblasts, the amount of collagen present, and specifically the ratio of type 3 to type 1 collagen. The clinical classification is the Dupuytren classification, which assesses each ray based on the total flexion contracture at the MCP and PIP joints. It is a modified staging system for the thumb. It includes a modified staging system for the thumb that incorporates the degree of first web space contracture, and there is also additional notation that localizes the lesion to the palm or the digit, which highlights extensive contracture at the PIP joint and hyperextension at the DIP joint, and it also accounts for postoperative changes. Here we can see the Dupuytren classification in further detail. Moving on to management. Management options include non-surgical and surgical management options. Non-surgical management includes percutaneous needle aponeurotomy, PNA, Collagenase clostridium histolyticum, CCH, and certain future therapies. Surgical management includes limited fasciectomy, radical fasciectomy, and dermatofasciectomy. Percutaneous needle aponeurotomy is a systematic percutaneous release of the cord from proximal to distal until the contracture is resolved. This can be done in the clinic under local anaesthetic or in the operating theatre. The features include rapid recovery and less time out of work compared to surgery. A study by Molenkamp et al. Of 451 patients found an 85% correction of the pre-op passive extension deficit. Complications include skin tears, superficial infection, transient paresthesias, and more rarely, nerve laceration or tendon rupture. Long-term recurrence is reported between 12 and 58% at between 2 and 3 years. The targeted area is anaesthetized, as you can see seen in figure A. The bevel of a needle is used to clear a path over the cord. The needle is then advanced to perforate the cord, and a side-to-side sweeping maneuver is done until the cord is released from superficial to deep. Collagenase clostridium histolyticum, or CCH, is an enzyme which lyses cord tissue, allowing for disruption with gentle manipulation. It's only been in use for the last decade, so it's relatively novel. A study by Hurst et al. In 2009, which was a phase 3 clinical trial of 308 patients with a contracture of 20 degrees or more, found that 64% had a reduction to between 0 and 5 degrees at 30 days post-injection. The reported recurrence is 23%. It's been reported to have 23% recurrence or progression at 4 years. Cost is a limiting factor. On a per-digit basis, after PNA, CCH, and open fasciectomy at 5 years, the cost was $1,540, $5,952, and $5,507 respectively. So it's the more expensive of the options. It is also reported to have a higher complication rate than PNA. In terms of future therapies, clinical trials have been examining corticosteroid use. Yin et al. In a series of 49 diseased hands injected with triamcinolone. At 5 years, only 2 patients had reactivation of treated nodules. There is also potential for immunomodulatory drugs targeting underlying pathophysiology. In terms of surgical management, this is indicated if the MCP contracture is more than or equal to 30 degrees or if there's any PIP contracture present. Options, as mentioned, include limited fasciectomy, radical fasciectomy, and dermatofasciectomy, limited fasciectomy being the most common. Radical fasciectomy involves concomitant excision of adjacent pathologic and normal palmar aponeurosis to try and reduce the chance of recurrence. Dermatofasciectomy involves the additional removal of the overlying skin and covering the wound with a full thickness skin graft, which is used more in recurrent disease. The limited fasciectomy allows preservation of the overlying skin. Removal of the entire diseased portion of the aponeurosis from proximal to distal is necessary with appropriate skin incision, while paying close attention to the neurovascular bundles. Care should be taken to avoid crossing a flexion crease at 90 degrees. Options for this sort of skin incision include a Z-plasty. Postoperatively, early hand therapy for active range of motion is important, with or without a nighttime splint. Complications of this procedure include neurovascular injury, transient ischemia, stiffness, tendon injury, wound issues, and infection. There is a lower recurrence rate with surgical management than non-operative management. Leafblad et al. Found that at 5 years, 50% of CCH or PNA patients required re-intervention compared to just 4% of fasciectomy patients. In summary, fibroproliferative disorder of the palmar fascia of the hand, Dupuytren's disease, can be characterized as this. It leads to progressive contractures, mainly in the ulnar digits, affecting the MCP and PIP joints. No clear treatment algorithm exists with a number of non-operative and operative options. Here are my references. Thank you.